We have a 25-year-old patient who was referred for gastroparesis, who had a prolonged gastric emptying test, and who was referred for a GPOM. There was no food in the stomach during this examination. I don't think there was in the one before. But she does have a gastroparesis.
The only information we have about the patient is that they had a prolonged gastric emptying. I think we also did endoflip, right?
And seeing the delayed gastric emptying, it's something worth trying, I guess. I don't know, what do you guys think?
Yes, that's exactly what David said as well. The patients have tried many, many things before. What are their options? I've seen spectacular results, both physically, as in they gained a little bit of weight when they were too skinny, but also mentally, just because of the fact that they wouldn't feel this discomfort the whole time. It's definitely worth a try. We are following up all the cases here in Ghent, of course, but it's a bit early to speak of definitive outcomes.
Would you agree with that statement, Zander?
Absolutely, absolutely. Especially in the most spectacular ones are the postoperative pylorospasms, of course. But definitely also in a subset of the idiopathic patients, although some of them...
There are, of course, some who don't have any result. And I think there are some who have a spectacular result and never come back. So, yeah, I think we need to select the cases. So let's just, I'm going to let you do the myotomy, but this is a good image to see, right? So what are we seeing in this image?
Submucosal and duodenal mucosa, I think.
Yeah, flipping down behind. Yeah. So it is going behind the pylorus, and there's really hardly any submucosa. So if I open the knife there, it will go through, and then we'll have a world of pain. So let's not do that. So what you want is to be at the back quite dissected. Yeah. So I think we're all right, actually. So when I put the knife down here, you've got to really trust the assistant. Open, please. Then you just can do a little bit at the back here to make sure it's completely open. And this is really, really important because once you're going to put the IT knife down there, IT please, which we're going to do now and you're going to do, then we have to make sure that there is space for it behind there. Because if there's not space for it, what happens is you just get an incomplete thing and then you have to use the triangle again. And it's a world of pain that you can avoid by doing that. Yeah, nano is fine. You got two types of IT knife from Olympus. You got nano and you got the 2. The nano is better, I think, in my opinion, because the 2 is cutting on the edges a bit. Right, I'll show you the technique, but I won't do it. And then you...
in the cut Q effect 2?
Yeah, in the cut Q effect 2. So what we were using for the whole procedure until now, apart from the incision, which was in the cut Q effect 2, was spray 4, right?
Yep.
Okay, so open. So 2 critical things. This goes behind, but you can see it will go behind because I created the space. And the second thing is the orientation, right? So you cut down like this, you will not achieve a complete myotomy. You need to cut in the 6. It's quite hard with a gastroscope. It usually involves a lot of anti-clockwise torque to get this sort of V shape on it, right?
Yeah.
Like this.
And you pull on the knife.
Well, you first do some taps, right? So your first move is I'm tractioning on it, yeah? Really, I'm tractioning with a small wheel, you know, thing. I'm testing, is that good? Not really. Is that good? Yeah. Is that good? Not really. So I'm really getting to the position I want to be in. Yep. This is going to come into the 6 o'clock, yeah? Then, normally, I'm trying to get the maximum amount of the pylorus in it as possible. Okay, this looks pretty good. And then it's tap on this. And just do a few taps without doing anything else. Like, don't pull on it. Yep. And when you see it's not doing anything else, then start to pull on it back into the scope, right?
Okay.
What could possibly go wrong? Don't be too quick on the pedal, yeah. Let's agree on the thing first. So you've done the anti-clockwise. That's nice. Gently put, yeah, nice. Maybe, yeah, it's good. Try and really get a V there with small wheel, maximum anti-clockwise. Yeah, like this, I think. Okay. Let's do one tap and see what happens on the yellow. Yeah, good. One. That's, wait, that looked like spray. Strange. Try again on the yellow. What was that? You pressed yellow.
Yes, I did.
It's probably the first, like the correlation.
No, that was a
felt.
spray pulse, definitely.
Really?
Weird.
That was for sure yellow. I saw it.
Strange. Okay.
I think I tried to listen as much as I could to what you said and do what you said.
What do you mean about as much as you could? Because it was hard to listen while you were doing, you think? Or?
Well, because the maneuvering in the tunnel wasn't always as easy. I haven't tunneled before yet, I guess. So it always looks easier than it felt like. So trying to get my knife in the exact place where you wanted it to be was not always as easy as I would have hoped. Let's say.
Okay. So what you actually mean is executing the thing. You understood everything I said. Executing what I said was the difficult part sometimes.